Welcome, everyone. My name is Ed Hallrott, and I'm the program coordinator for Advanced Rhode Island CTR. And today, in Sharon's absence, I have the pleasure of moderating the seminar in the Advanced Rhode Island CTR Clinical and Translational Research Seminar Series. We are very fortunate to have Dr. James Rudolph present today on his research. Dr. Rudolph is a professor of medicine and also in the Department of Health Policy and Practice at Brown University, and he directs the VA Center of Innovation in Long-Term Services and Supports. He is a clinician, researcher, and educator, and I'm happy to say that Dr. Rudolph recently received the Beckwith Family Award for Outstanding Teaching. He is an active clinician who works with interdisciplinary teams to identify at-risk patients, modify the risk, and provide medical care with a focus on functionality. Driven by his clinical work, he works with the health system to develop and implement changes that improve the lives of older people. He has over 150 peer-reviewed scientific publications. Additionally, he was the founding president of the American Delirium Society, ADS, serves on the ADS Board of Directors, and co-chaired the recent 2023 ADS conference, which was located here in Providence, Rhode Island. Dr. Rudolph's title of his presentation today is, as you see on the screen, Complexity, Perplexity, Simplifying Clinical Aging Research. Dr. Rudolph.
Thanks, Ed, and thanks to everyone in the audience for attending. It's really great to be with the Advanced CTR. I hope everyone realizes what a great asset having this grant is to the state of Rhode Island. It is really a resource that we should treasure. All right, we've already gone over the title, so we're gonna move on. A few disclosures. I have grants that are funded by VA, NIH, Brown Physicians, Lifespan, and I do some nursing home work for a company called ICASAVAX. Also, I am a VA employee, and that means the article or what I talk about today are those of my own thoughts and my own words, and they don't respect or reflect the official policies or positions of the United States government or the Department of Veterans Affairs. What I'm planning to do over the next 45 minutes or so is to define aging as best we can, and then discuss the challenges of time and how it impacts on aging, and then ultimately, my hope is that you'll come and think about aging research and want to join our party at some point in time. I start a lot of talks out with this slide, and I think this is a talk about aging, not about death. But death is a part of our life process, and it is really it becomes increasingly common as we age. And so we often talk about death as a negative outcome. And in reality, it's a very natural part of the aging process and of life. Our world is in this aging process. If you look, this is a United Nations report. And what we see is that over the next 25 years or so, there's going to be massive growth in the number of people who are over the age of 60. In the U.S., we're panicked about this. We only have 44 million people who are going to become older, and that's a 57% growth. If you look at other areas, Asia, Africa, South America, massive growth. As people age, they become dependent in the infrastructure of the country, and you can imagine that if a country was set up to manage 100 million older people, and all of a sudden that doubles to 200 million older people in a span of 25 years, there's going to be a lot of infrastructure needed to manage that. We're going to watch the world as it ages, and it's really both exciting and incredibly scary. And so, we have our challenges in North America. If you were in Asia and you're about to see 724 or 750 million more older people, that's some real infrastructure that needs to be developed. And that's why we're here, right? Is to hopefully engage in the process of understanding what's needed and how best to deliver that. So as we define aging, we start to look at some of the features. Now, it depends where you live in your research and in your occupational sphere as to how you go on and define this. There are some basic scientists among us, and they tend to use a very biologic definition of aging. Environmental exposures lead to oxidative stress, which lead to genetic damage and cellular senescence. And as these environmental exposures accumulate over time, the damage gets worse and worse, and we see increasing or decreasing cellular function. For those of us who are clinicians, we look at this and we go, boy, as people age, we start to see very early on in life, actually, a reduced ability to bounce back from stressors. And then comes the accumulation of disease and a decline in function overall. And that's what we're seeing. And then there are those of us who study populations. And what we see is that there's a increased dependence, that people can no longer maintain their independence. And that leads to social isolation, increased mortality. We also know that there's accumulation of comorbidities and an extensive heterogeneity. Where I define the key features of aging are, there's always a function of time. Now that time function can be variable amongst people, but time is a component of it. We see a decline in function is inherent, and that this applies whether you work in cellular. There's a decline in cellular function. There's a decline in physiologic function, and there's a decline in social and population function as well. The diminished stress response, I call this resilience, and that is the body's ability to respond to a stressor decreases as we age. It's why football players don't play into their 40s. It's because the body just begins to not be able to bounce back from all of those hits that are taken. And then, as I mentioned, there's a heterogeneity, or that each of us becomes increasingly unique as we age. That's awesome. I love being unique. When we're thinking about all of this from a aging research standpoint, we really are looking to create logical explanations for things. We propose experiments where we look at exposures, time goes by, we look at our outcomes, and we say, all right, all this happens in a population, and therefore we begin to make these logical connections. All of science is built on this, whether you're studying biologic function or cellular function, and you're inducing genetic mutations to look at altered protein expression, whether you're looking at the impact of antipsychotic medications on swallow function or chemotherapy on tumor shrinkage. All of these, exposure, time passes, we look for the outcome. In population, we also do similar things. You shift the water source, and all of a sudden children develop lead poisoning. Or you're at that quintessential board question where you're at the picnic in the hot sun, and the food is left out, and 3 hours later everyone's having GI distress. Those are exposures and outcomes, and it's the logic we seek in science. As we're looking at this logic equation, and particularly as we're looking at it with that lens of aging research, we know that the variability that happens with age, that heterogeneity, it really messes with the logic. And so that variability is a key component of aging research. Now, I'm a father, And the whole premise for this talk actually originated from a dad joke. So bear with me, all right? Two hydrogen atoms walk into a bar, and one turns to the other and says, "Hey, I think I've lost an electron." The other goes, "Are you sure?" "Yes, I'm positive." All right. We know that hydrogen ions or hydrogen atoms exist in an equilibrium, right? And if hydrogen atoms exist in an equilibrium, then everything with hydrogen exists in an equilibrium as well. These are cool pictures of the electron densities of hydrogen atoms, but notice the fuzziness around them. There's a central core and then a lightness as we get away from there. There's variability in the equilibrium of the hydrogen electron field. There's variability in the equilibrium of the hydrogen association. And that means everything that has hydrogen in it, including that important substance named water, has variability. And all of them exist in an equilibrium. We know that our energy systems critically dependent also on these hydrogen ions, as is our cellular respiration. All right. It's almost like there's a flow of energy created by all living things, and it surrounds us and penetrates us and binds us together in the galaxy. Now, I know this is a group of scientists, and I apologize. I know Wikipedia is not often considered a reliable resource, but I found Wikipedia to be a very reliable resource for Star Wars jokes. All right, maybe not. Okay. So as I was going through this dad joke, I was looking for others who might share this idea that there's a perspective on this flow of energy. And so I found this guy, and he was originally pretty. I thought he was really in balance, but he tended to lean towards the dark side a little. Seriously, equilibrium theory, this whole idea that things are in balance, it permeates science, right? It is the whole basis for our homeostasis, that we exist in an equilibrium. We function best in a native environment. As I was talking about resilience earlier, that ability that we bounce back when faced with a stressor, we return to that equilibrium. There are psychology is built around this equilibrium that people look to live and engage in a mentally stable environment. There's ecological balance, and I really think that the home environment is really built around this idea that things exist in a balance. All right. I'll let that one everyone read that one on their own. All right. The variability we see really messes with our logic. Particularly in aging research, when we look at variability, we're looking at variability in exposures, we're looking at variability in our time, we're looking at variability in the outcomes, and we're looking at variability in the population. And that makes it really, really hard to do science in this in older people, and as well in aging systems. And so because there's so much variability, we seek out models of aging that allow us to make these steps of logic in our science world. So some people study cultures and cells, and some people study fruit flies and other insects. Other people study rodents. Some groups have put together cohorts of exceptional longevity. In this one, I always call out the Okinawan centenarian study because one of my fellows was the PI of that. We also can study aging in cohorts of exceptional morbidity and mortality, thinking of the ADRD, Alzheimer's disease research centers, and their cohorts that they assemble with Alzheimer's disease. But we know that the cancer folk put similar cohorts together. We also have cohorts of exceedingly stressful events. And in my world, I found the surgical cohort to be an amazing cohort to study aging because we're delivering such an intense stressor to folks, and we can measure both a baseline and a resilience or an after effect of that surgery, and so it's a really good model. What I'm here today to talk about is a different model, and my colleagues and I really spent a lot of time thinking about what is a model of premature biologic aging. We didn't spend a lot of time coming up with an acronym, and it turns out PBA has just a boatload of groups that use that acronym, from the Professional Bowlers Association to the Palm Beach Atlantic Sailfish, as well as the Pennsylvania Bar Association. Lots of people use PBA. I'm talking about premature biologic aging. The key features of a population with PBA: incredibly high stress. So that exposure is really intense. And what happens when they receive that exposure is that it shortens the time between exposure and outcome. And then we see high outcome prevalence in that population, either as a function of the exposure or the intense exposure of the stress, or because of the decreased resilience of aging. Our population that I want to talk about for premature biologic aging is people experiencing homelessness. Now, I'm very aware that homelessness is not one thing, right? And there's a lot of features of homelessness, or features of the group experiencing homelessness that build towards that homelessness. People experiencing homelessness tend to come from really difficult childhoods or really difficult life prior to that. And that includes both childhood trauma, low social supports to begin with, low coping mechanisms. In my world as a VA physician, that military transition, not only into the military, but also then out of the military into civilian life again. People experiencing homelessness tend to have high comorbidities, including mental health disorders, substance use disorders, and then end organ disease from other medical comorbidities. They also have a low social support structure, and they're much more likely to be single. They're clearly lacking in money and a lot of things, which would enable some of the social supports. So when we were thinking about homeless veterans as a model of premature biologic aging, we really wanted to get some face validity to this idea that PBA, or that homeless veterans could be used as a model of PBA. And so our initial thing was to look at veterans who were admitted to nursing homes, and then look backwards to see if they had a homeless ICD code. And our goal was, once they were admitted to the nursing home, we were going to look 90 days and 1 year after their admission to see if they still remained in the nursing home. We thought that this would give us some really quick face validity to whether veterans experiencing homelessness who were admitted to nursing homes stayed in the nursing home over the next year. The other part is we had the data at hand to be able to do this. So when we looked at this population, again, everyone here has been admitted to a nursing home. People who were experiencing homelessness were admitted a decade earlier to the nursing home than people who were not experiencing homelessness. They were, as I mentioned earlier, much more likely not to be married, high prevalence of mental health disorders, alcohol and drug use disorders, and liver disorders as well. So really a population that is different than the traditional nursing home population, and much, much younger. What we found is that those veterans who were admitted to a nursing home and experiencing homelessness were 12% more likely to be in the nursing home at 90 days. and then slightly more likely to be in the nursing home at 365 days. Interestingly, they were more likely to survive that nursing home stay. Again, attesting to a bit of their resilience relative to the group that wasn't. So we were empowered by this. We thought it was reasonable face validity for our hypothesis. And so we went off and we went looking, as scientists do, for another example of how homeless veterans could serve as a model of premature biologic aging. And so in the next experiment, we decided to look at measures of environmental equilibrium. These are measures of what people were experiencing. And we were going to look then at increased DNA methylation as a measure of premature biologic aging. I already mentioned methylation. I'm sorry, this study was going to compare homeless veterans versus non-homeless veterans. And so methylation is where these enzymes come along, drop a methyl group on cytosine. Methyl groups have hydrogen, so they're in variability. And that methyl group stops additional enzymes from replicating that gene and expressing it in the form of proteins. Theoretically, the more methylation you have going on, the more premature biologic aging is going on. So we really thought we really were convinced we were gonna find some premature biologic aging. We recruited 17 homeless veterans, 17 formerly homeless veterans, and 17 people who were never homeless. And we did way too many exposure variables in the measure of that environmental stability for the size of the population we had. This was both feasibility of being able to do the DNA methylation and honing in on our questions of what we were going to ask people about it. Yeah, but with all of these measures and doing probably way too many data analyses, we found only two significant predictors, and that was people who had early childhood traumas or grew up too fast or lost a family member before age 17 had an increased DNA methylation and about 4.2 years of premature biologic aging. Interestingly, the months of homelessness in the past 5 years had an inverse relationship. So there was less PBA per month of homelessness. And really, it sort of deflated our sales in a lot of ways in terms of what we thought about premature biologic aging. So many on this call are academics, and we're always supposed to talk about our successes. I think there's great opportunity in talking about some of the things that aren't successes. One of the beauties of working in the VA system is that we get to have a degree of innovation in an integrated health system. So we were asked to do some predictive analytics, and we took as many variables as we could find, and we were asked to predict long-term institutionalization or death in 2 years' time. And this was done on all enrolled veterans. So these are veterans who received their care within the VA system. This is a big analysis, and we started out with homelessness and then 148 other variables, and we looked back a year to capture those. And then we looked for our outcomes in the 2 years after. We did this in a 2017 cohort as our derivation cohort, and then a 2018 cohort as our validation cohort. So 2 extraordinary large cohorts. I learned a lot about big data in doing this. And one of the key things that happened here is that we broke our computer system. We tried to do some really innovative ways to hone down the list of variables. and ended up, we were doing analyses, or the computers were doing analyses and calculations for days because of just the size of our cohort. So we broke it down into a little bit more bite-sized chunks to do some of the more fancy variable selection and things like that. And really, at the end of the day, logistic regression proved to be one of our best ways to predict this. So that's what we ended up reporting on. You will see that of the variables that were selected out of the model, some of what you would expect: dementia leading to long-term care, understood. Homelessness was also in that mix, and we really viewed it as a important measure, particularly since we were engaged in a program that was subsequently going to deliver services to these people. So the pathway for the services to be delivered is much different when people are experiencing homelessness. We found, we can reduce the size of the haystack where we have to go looking for people with a high probability of a negative outcome. So we found a very high risk group of people that was seemingly actionable in our healthcare system. If you try and do an intervention on 4.7 million, you're going to really struggle. If you try and do an intervention on 17,000 folks across 170 medical centers, that's only 100 interventions per medical center. It's a lot more feasible. Our discrimination in our variable selection and our modeling was reasonable. It was on the borderline of good. And we had, again, a very high positive predictive value in that very high risk group. In addition to our primary outcomes, we also found that there were some really important secondary outcomes that were associated with that high risk group. Percent days alive in community is a measure of community dwelling, and in our very high risk group, over the next 2 years, while people were alive, they were spending 77% of their days at home, or 78% of their days at home. It's a pretty cool number. They accrued an enormous amount of costs over those 2 years, so almost $100,000 in each of those 17,000 people. They did, even that high risk group was, despite our interventions, was spending a long time in long-term care, and we did a reasonable job. About half of those had received some type of home and community-based service during that time frame. So we really viewed this as a success, but we struggled with some of that, the prediction part of it, because we weren't capturing everyone. It reminded me of a quote from Yoda: "Difficult to see, always in motion is the future." And that brings up really some important concepts to us. If Yoda struggled to see the future, and we as normal mere humans without a strong component of the force would struggle to see it too. In the end, we really wanted to do an analysis to understand whether all of this work in homelessness was worth it. And we did an analysis of whether a change in policy can affect homelessness. And so the VA instituted a policy to end veteran homelessness. And we were going to look ultimately at veteran homelessness. And this included all veterans, not just those who were enrolled in VA healthcare system. Ultimately, it's a question of, can we move a needle on a social determinant? And this is not a social need. This is actually a wide scale. Can systemic change really change social determinants of health? The VA initiative to end veteran homelessness began when Secretary Shinseki took over in late 2008, early 2009, and it was his signature priority. and remains a strong priority in the VA system to today. It was a multi-pronged strategy. So first, housing first was the idea. Veterans who are experiencing homelessness have lots of things going on. Our goal was to get people housed. To do that, we needed to understand. We needed to do assessments of housing. We also needed to provide some type of program for veterans who were experiencing homelessness so that they could be housed. And again, VA reallocated resources. Congress devoted extra resources to this. We looked then at the point in time counts, which are conducted annually, independent of VA. But the point in time counts, or the PIT counts, do include veterans. And then we looked at internal VA metrics as well. So here's the bottom line. When we started the program to end veteran homelessness in 2009, which would be reflected in a January 2010 PIT count, we watched a 55% decline in homelessness during the time, or during the program years that we did this evaluation. Effectively, by assessing veterans' housing needs, by just getting veterans housing as a first step, we were able to reduce these PIT counts for veterans. Also, when we look, or one of the key ways we did that is through HUD-VASH vouchers. So HUD-VASH provides a Section 8 voucher so that there's reasonably stable housing. In Rhode Island, a HUD-VASH voucher will get you stable housing. In LA, a HUD-VASH voucher probably won't get you stable housing in the city limits of LA or LA County. You're going to have to go pretty far out for that voucher to work. You can see that the number of vouchers VA delivers to veterans has increased dramatically over the years. And these are not cumulative counts, these are annual counts. We are also looking at other grants to other agencies to help social service veteran foundation grants, where we were giving grants to other agencies to engage veterans to try and get them into housing. And we've seen really, really great numbers of veterans housed as a result of this. Within VA, these are internal tracking numbers, but we also saw that within the PIT counts. So we really, VA did a remarkable job in this. And as we're wrapping up here, aging research is a constantly shifting equilibrium. We've got poor measures of exposure. We got poor measures of outcome. We don't measure time between exposures and outcome often, and our population varies and is heterogeneous. So it makes it hard. The other parts of it that make aging research hard are that the data is designed to maximize billing and may not reflect accurately what we're seeing clinically. We're designed, when the billing systems step in, we're really focused on capturing data that reimburses the most, not what is most relevant to the veteran or the person. It also, a lot of times, diagnoses don't matter. When the social needs predominate, it really is not. It's less relevant to that. We know that there are forces out there that are much more focused on measurable outcomes with numbers and drugs associated with them, and performance metrics now too, that really push some of the other treatments where we don't often step back and think about this. And ultimately, data is part of the answer, but it's not the entirety of that. we're all individuals, and we all have our own force within us, and we really have incredible variability in what we want and what we need, and the system itself doesn't have the capacity to really meet everyone's need, let alone their wants. And this is going to get way worse as increasing numbers of people age, so that we aren't going to be able to meet everyone's needs unless we dramatically shift our infrastructure. These constraints on our system are a real bound to us as we do that, or as we try to do aging research and as we engage in this. So in my final couple slides, I really want to highlight that, you know, we've learned a lot. We continue to put forth hypotheses, some of which work, some of which don't work. It really allows us to go back and engage. It's a really exciting field in aging research, in my opinion. First, unlimited opportunity. Regardless of your own field, there's a translation into aging research, and it really allows you to engage and make really good discoveries that really can enhance our knowledge going forward. There's also the ability to partner and engage with people in areas that we've never expected before, and that's really cool. You can create solutions to challenges that are both within this world and well beyond this world. The best part for me is that even a small innovation brings impact. We had a program once where we were helping older people sleep during the hospitalization, and you'd be surprised how much that changes someone's world when you can get them one good night of sleep during their hospitalization. We learned in the advanced CTR announcement earlier today that AI is coming to us. Right now, the AI overlords who are looking at aging are using crappy data. And so we can, at the very least, feed better data into our AI overlords, and ultimately building steps of that logic equation in aging, really critical. So aging research also lets you pick the scope of your work. You know, I'm a geriatrician who sits at the Providence VA, but all of a sudden we're engaged in work that has national impact because we're in an area where there's not a lot of people who are engaged. And so there's real opportunity in aging research to have innovation locally as well as more globally and certainly nationally. So a few recommendations for aging scientists like myself and scientists who study aging. I happen to be both. The first is to be bold. Second is don't be arrogant. We have to respect the variability that comes with aging research, and embracing the complexity of aging. We're going to put forth logic equations. We're not going to have the answer. So we're not always going to have the answer. So there's real complexity with all of this. Small gains in logic, small gains in knowledge really have value. The other part I'll tell everyone is don't sell the snake oil and don't be sold by the snake oil. Because aging is increasingly common, there's a lot of people out there pushing things that are not scientifically based or are crappily scientifically based. And you know, we really need good science. Otherwise, we're all going to be put down pathways or be sold pathways that really don't reflect the science. All right. so I started with a dad joke, and I got to end up with a dad joke. And the dad joke is, I don't believe in atoms; they make up everything. Sorry. Um, every science dad who's ever taught a chemistry course has used that one at one point in time. I am very thankful to my collaborators on this. Many people helped us develop our structure or our theories behind premature biologic aging. I don't know that we've hit it entirely with the homeless or with those people experiencing homelessness, but I know we have more knowledge in that area than we had before, and it's really an exciting time to me to be engaged both in a population that has so much need, and to be able to engage with them within a healthcare system that really seeks to engage them and provide for better health for them. So that's where I will stop, and we can jump to the chat and any questions that may come up.
Thank you. Yes, there's a couple questions, and I have one as well. Let's see. So first of all, how would you differentiate the concept of premature biological aging from the concept of frailty?
Okay, and so there's the concept of frailty and the frailty definitions. It's well known that there's a lot of clear-cut definitions of frailty out there. I think premature biologic aging is within the pathway to frailty. Frailty to me is a decreased inability or an inability to respond to stressors. And so it's more of an end stage disease, where I see premature biologic aging as some of the underpinnings as to how we get to that end stage frailty. And so I think there's a time component that's different in there. And then there's the biologic underpinning. To me, again, frailty is more of that end organ dysfunction that where the organ can't respond to the stress.
Thank you. Another question, Stephen Kogut says, terrific talk. Thank you for sharing this information with us. Could you please talk a little about factors that are challenging to measure, such as nutrition, and that was the one area that I was going to mention, heredity, et cetera. That is, how much outcome can we expect to predict with the usual variables available in claims EHR data? And he notes in a PS, I heard that Darth Vader doesn't eat ice cream because he is galactose intolerant.
All right. Hey, another dad out there. That's awesome. Thank you. Yeah, so there's a lot of variability, and I can't speak to nutrition and heredity as much as I can speak to cognitive impairment. And in general, we're terrible at measuring cognitive impairment in claims and billing. I mean, really, really bad. My early work on delirium, we found we were undercoding by close to 80% in that group alone, and it makes it really, really hard, particularly when the codes don't pay. Nutrition probably doesn't outside of very end stage disease, probably doesn't pay a lot, and so you're not going to get a lot of people taking up that code. I think there's a couple things. First is, I think the more we can engage patient-reported outcomes, then we're gonna do better in measuring some of these, because we can't, if we're depending on clinicians who are generating codes to do it, not going to go well. If we're depending on patients themselves to report it, perhaps we're going to do a little bit better on that. The heredity components are very interesting to me, and particularly because I work with the VA. Imagine this, that the VA has now recruited 1 million veterans into a study looking at genomics of that million veteran cohort. In addition to the 25 years of electronic medical record data, we have over 800,000 SNPs in that cohort. So, that data set gets really, really big, really, really quickly when you think about it. And I think that big cohorts like that are really where we're going to have the power to be able to capture some of those components of heredity. It's really the VA has invested heavily in this genomic cohort, but it is really, really going to be exciting, some of the things we discover out of that. At the same time, once someone gets to 80 years old, I'm not betting on a lot of things from heredity contributing to disease processes there, particularly since they've had 80 years of life exposure. We're not going to be able to measure what their water was like when they were growing up, or did they live near a power line, or what was the air quality in 1942. All of things I don't know, and we don't have measures for a lot of those life exposures that theoretically can have big impacts on people's lives. And so we're measuring more data than ever before, and we'll probably learn from that, learn how to measure exposures. But on an individual level, measuring lifelong exposures is very, very hard.
Hey, thank you. So doesn't appear to be any more questions. Let's see. No, don't see anything. So, all right, to end then, I'd like to thank you, Dr. Rudolph, for a very informative and I'd say provocative presentation with regards to growing population. We're all going to be entering that area, and I appreciate your advice to young researchers who are contemplating working in aging research and the various aspects of that. I'd also like to thank our participants for attending today, and we look forward to your continued participation. This is the last seminar for this academic year, but we plan to start up again in September. So please pay attention to the announcements that will be coming out in the Advanced CTR, Rhode Island CTR newsletter that will give the timeline for the next set of presentations. So also along the lines of May the Force be with you, I just noticed that there's a website called English to Yoda Lingo Jam, so you could translate your phrases.
I don't know. Is it as reliable as Wikipedia?
Right.
Thank you.
Okay.
Thank you
Thank you
everyone
very
for your
much.
attention. Really appreciate it.
Yeah.
Bye.
Bye for now.